And so now it's time to open the space for a question and or comments. We have a question for Dr. Haberbosch. Are there any side effects or contraindication for growth hormone replacement? And is there any information regarding the usage of growth hormone in patients with diabetes?
I think that might be a question for the both of us, but I can certainly give my perspective on that, which is you have to consider that when you're trying to replace growth hormone, you're normally just trying to bring growth hormone back up to the normal level in that person. So it's not like you're doing growth hormone doping, in which case we would have a lot of contraindications and a lot of side effects. There are some side effects you have to deal with because of injection site problems and possible infections and so on. But regarding the two relevant ones, one has been brought up, which is diabetes. So growth hormone does have an influence on insulin resistance and will increase insulin resistance. But in a way, it will just bring it back to the level where it normally would be. So if the patient unfortunately already has diabetes while being growth hormone deficient, it would have been worse if he had always had growth hormone. So you will bring it back to that level and you will make it slightly worse. So it's highly important that you do it's regular checkups of blood glucose parameters during that time, that you carefully adjust the therapy. And the second side effect that hasn't been brought up is, of course, you always fear the risk of tumor growth on a growth hormone, which is why growth hormone is not used for anti-aging purposes. Right, so at a certain point, growth hormone does not cause neoplasia to appear out of nowhere, but if there is a tumor, it will grow with growth hormone. And I tend to tell my patients, I tell the story to my patients that way, that they are, by growth hormone deficiency, they are slightly protected against tumor growth. If we would replace growth hormone, we would just take this advantage basically in that field away, and we would return their risk to their normal risk. So that is something to consider. People with active growing, fast growing tumors should not tendentially receive growth hormone.
Okay, thank you. And the other question, I think it's for Dr. Haberbosch. What's the etiology of the patient's pituitary insufficiencies? Excuse me for my pronunciation.
So the patient had a suspicious growth detected in the sellar region via MRI, I think because of headache at some point or an injury, and that was mistakenly thought to be a pituitary adenoma, and the patient received pituitary neurosurgery, but it turned out there was no pituitary adenoma to resect. They resected all they found, but it was, in hindsight, most likely hypophysitis. So it was pituitary surgery, in a way iatrogenic, so caused by medical procedure.
Okay, thank you. And a question for Anne. What do you think about the current available guidelines? Do they adequately support nurse-led management of growth hormone deficiency?
Is this in relation to the National Institute of Clinical Excellence guidelines? Yeah. So I think they support nurses definitely, but I think in advanced practice. So if you follow through the guidelines, you know, the guidelines are very much about titrating the dose efficiently and effectively. And I think realistically, within clinical services, nurses probably have more time where they can actually spend discussing with the patient, especially in geographical areas where we have huge populations, which in the UK, as you're probably aware, we have high population in quite dense population as well. So I think the guidelines do support nursing. However, It's a really good question, because I suppose I haven't really thought about that before, because we're practicing in a way where we have to embrace the NICE guidance, because otherwise we wouldn't be able to treat our patients. So but I think with any pathway of care, it's always very helpful to have guidance, and especially from a nursing perspective, that we can actually follow, and where we have a goal alongside our patient. And of course our goal is to hopefully our patient's going to improve and feel better. Their quality of life will improve, their muscle mass will improve, they'll reduce their adipose fat, their socioeconomic status should improve, because I didn't really allude to that, but lots of growth hormone deficient adults, just in the nature of how they're feeling about their body shape, they have issues with relationships, with working, with holding down their job. Yes, but I'd be really interested in understanding different countries' perspectives as well.
Okay. Connecting to your comment, to your answer, I just want to ask you, you told that the guidelines support the nurses at a high level. But how can nurses in other countries that doesn't have the advanced nurse, how can the nurse contribute to improving early identification and referral for patients with suspected growth hormone deficiency? I ask you this question because, for example, in my country, in Italy, we need to grow up from this point of view in the topic of growth hormone deficiency. So I just want to ask you this.
Thank you, Valentina. So I think using the competency framework and starting to work through that, it's just such a good tool for nurses of all levels to start with, and also working within your team, so working with the other clinicians and approaching your endocrinologist, who I'm sure you work very closely with, but just showing them an actual framework where you can actually demonstrate, and you can be measured against that as well, which of course is increasing your capability of actually delivering this care, but within the framework of good clinical governance. So your team around you can also be very assured that you are following a guideline, and so that promotes safety, it promotes the other clinicians within your service, gives them the confidence that as a nurse you are following a guideline, and I think increasing our knowledge as nurses, increasing our physiological knowledge around the conditions, so not just treating endocrine conditions, but have a true understanding and increasing the capabilities of those 4 levels of practice. So increasing your clinical knowledge will increase your educational skills, will increase everything around you as a nurse, will increase your leadership capability, be involved in research as well. I'm sure all of you are working where there is some research going on in your hospitals. You might not be affiliated to a teaching hospital, but You know, the journals are available online. You can do your own literature reviews, look at the subject of growth hormone deficiency. There is an awful lot published now on growth hormone deficiency. And actually there is a lot published from nurses, especially in Australia and America and the UK. So yes, I think it's an approach to your colleagues and to the endocrinologist that you're working with.
Thank you, and I agree with you. In fact, for Italy, the Italian Association wants to use your beautiful, amazing work about the framework of competencies to let the endocrinology nurses in Italy grow from various levels. Thank you. Now I have a question for Dr. Haberbosch. In adult patients, besides measuring IGF-1 levels, do you assess adherence to growth hormone therapy in other ways as well? For example, through injection diaries or by tracking waste from the device used? Maybe it's for Anne or both of us.
And go ahead.
So our biochemical monitoring, we obviously look at the IGF-1. So in terms, I think again, it's really getting to know your patient. You'll get to know your patient by seeing them regularly. But through measuring quality of life as well. So that's one way that we really see improvement. And then, you know, just the general communication with the patient. You know, I can see a patient walk through the door 3 months into treatment and they will be a different person. And, you know, more confident, lost a little bit of weight, able to go to the gym. You know, we all know the growth hormone deficient adult who will say to us initially, gosh, I go to the gym and I do this and I do that, nothing happens, you know, my arms stay thin, my tummy stays big. So I think there's lots of ways of measuring compliance. And IGF-1 is, yes, it's the biochemical aspect, but it's so much more than that with growth hormone deficiency. And again, that's why in the UK we allude to it as more of a therapy rather than a very specific, you have to have this treatment kind of, you know, it's not, it's a therapy. But hence that then causes us to run into trouble with commissioning and you know, prescribers still have the choice that they don't have to prescribe it if they don't feel that they're expert enough to manage it. And I'm sure Dr. Haberbosch will agree as well, but there's still some discussion within the endocrine community about the benefit of growth hormone, especially in adults.
That's why I run around presenting this case, because I think it's really crucially important. Yeah. And just to answer this question as well, so I don't measure device waste or something like this in addition, and I don't necessarily, if I don't trust the patient to take the medication, I don't trust their diaries either. So I'm intending to also rely on my clinical assessment, just in general, quality of life measurements and IGF-1 in the combination. That's what I would say.
Okay, so the trust is the key word. Another question, can growth hormone worsen other conditions, symptoms aside tumors?
So maybe I'll start on this one. So there are a couple of things to consider. So diabetes we already talked about. It tends to, it could in some cases cause swelling and edema, or rather, again, try to word it differently, it would return these states to normal. And for example, in Prader-Willi children who are severely overweight and have problems with sleep apnea and already a very small airway, this might worsen this. But other than that, I think if you dose it correctly, it doesn't do much. It doesn't worsen too many conditions. It rather returns the state to normal.
So the only thing I would add to that is if a patient is thyroid deficient as well, I do watch the free T4 because growth hormone treatment can suppress that axis. And so sometimes you will just need to again, if you're a nurse prescriber, or you would discuss with your consultant the biochemical results. So if you see the free T4 just dropping down, you might want to consider just giving a small amount more. It's normally negligible, 25 micrograms more, 50 micrograms more. This is probably more into maybe, I'd say it more, it's about 6-7 months of treatment. So a naive patient starting treatment. But otherwise, maybe the only other thing to mention is women on oral estrogen. Oral estrogens tend to suppress the growth hormone replacement. So those ladies tend to need more growth hormone per day. So if it's not contraindicatory to the woman, we would probably look at transdermal preparation or gels. There's so many ways now that ladies can have HRT. I think we're more mindful of that in the UK because of cost, but also just trying to deliver to the patient the requirements, lower requirements if we can provide that. It's always better probably to have less than more.
Okay, thank you. Another question for Anne. Can you give an example how you interpret the the questionnaire for growth hormone deficiency?
Yes.
How do you process this to a personal report in the patient status?
So the quality of life. So to even be able to receive growth hormone in the United Kingdom, they have to have scored 11 points or more. So it's a score out of 25. 0 is fantastic. And I used to work with a professor who also always used to remind me that even on a good day, he was a 5. So I think to be a 0 on the quality of life, you just need to be the super duper human being. So each tick, so the patient has to tick yes or no. Each tick of a yes is a score of 1. So if you get to 11 yeses, your quality of life is pretty impaired. Now, most patients I see initially in clinic, they're scoring 21, 22, and they're really in quite a poor way. They're not really socializing, not really interacting at all. And in severe growth hormone deficiency, and where an adult has been deficient for a longer period of time, obviously this is built up over the years, and they are becoming worse and worse in terms of their quality of life. So I would repeat the quality of life probably maybe I'd probably wait till 3 months from starting treatment, because otherwise it's just a bit too soon and you just get a false reading. Because we also have to be really mindful that patients, the more they come to see us, that empowers them as well, makes them feel better. So some of these adults, they don't have a lot of interaction with people, so actually going to see the nurse once a month or once every couple of months, you're going to feel, so you're going to get a little placebo effect there as well. But actually the placebo effect, that does go off. It's like anything in life, it will filter off. and then you will see the true effects of the growth hormone replacement. And so I would be taking those measurements maybe at 3 months, 6 months, and then at 9 months, where I have to do my full clinical appraisal of the patient and then record. So this would all be recorded in electronic patient records, which we use. We don't use any paper. We just do everything on electric patient records. And then the quality of life, as it improves, this would be shared with the GP, so the general practitioner. So I know it's different in different countries, but these are the doctors that look after our patients in their community, so their villages, their towns where they live. And as I say, your aim is that you will improve by 7 points. And according to the NICE guidance, they have to improve by 7 points at 9 months.
I quickly add to that, I think the question, how do you interpret the ACTA score? That's one of the reasons why we don't use that, for example. And I know the UK is sort of bound to this by regulation, but I think that's why we use a PROMIS as a system where we have a T-score and standard deviations from the general population, which I think it's much more intuitive to understand what that means, how much worse the patient is than the general population, how much better he got since last time. But I think it's in your rules that you have to use this specific questionnaire. But I think there is a chance for very normative, easy to understand questionnaires like PROMIS.
Okay, so we are at the end, and we have other 2 questions, but we have no more time. So maybe I can ask to Dr. Haberbosch the last one, and maybe the other question we can type by Dr. Haberbosch, because also the second one is for him. So does all tumor types grow by growth hormone therapy? What about craniopharyngioma?
I'm trying to be as short as possible, so I'm not going to go into the depth of discussion. Just very short. In vitro data generally shows that most tumors grow by growth hormone. In vivo data and real clinical data does not necessarily show this. So the recommendations we're following do not contraindicate growth hormone therapy in general with craniopharyngioma, especially not if the disease is in remission. But there is an in vitro concern. So the mechanism is probably there, and most craniopharyngiomas express GH receptors. So there is the possibility. You just have to talk honestly with the patient about the data. And I tend to not see this as an absolute contraindication, definitely not. If the patient has if it was a patient like the one I showed, I would try growth hormone therapy instead of just accepting this quality of life and telling him otherwise the tumor will come back. So that's a short answer.
Thank you. Very short. About the last 2 questions, Dr. Haberbosch, can you type after, so we can go at the end? Listening to both of presentations, I believe we have to remind how important is to approach growth hormone deficiency not only as a clinical condition, but as a shared care journey. On behalf of everyone here, I'd like to thank both Dr. Haberbosch and Merland for their valuable contributions. And let me remind you the next events that you can see in the screen. And I hope to see you in Prague the next year for the European Congress. And I hope you a good continuing of the next events.